Elephant. એટલું મોડું કર્યું છે.
Yes, good morning, welcome friends. Welcome to Saturday morning meeting. And today we have Dr. V.C. Chauhan with us. He's a very eminent and very senior interventional cardiologist in Baroda. He was one of the first actually to start interventional cardiology in the state of Gujarat. He was trained at St. Vincent Hospital, Melbourne, and been practicing in Vadodara since 1993. And he's mainly affiliated, his work is mainly done at Baida Lamin General Hospital. With this brief introduction, I request Dr. V.C. Chauhan to start his talk on recent advances in cardiology. V.C., you have about 40 minutes to talk.
Yeah.
And then we'll have 10-15 minutes of discussion. So over to you, Dr. V.C.
Satish, thank you very much for inviting me. And Saturday Club, I know, is one of the oldest academic club that we ever had in Baroda. And actually, all the academic activity that followed, we can say, it's because of Saturday Club. I remember Dr. Satish Shah and Vaishnav Sahib and everyone starting this club many years ago. And I think one of the most persistent, and fortunately, even with the Corona on, you continued this legacy on online, which is really great. So I also thank all the people who started and who are joining this at early morning, because in India it's very early morning at the home. And I'll restart sharing the screen.
What today is?
Satish, can you see the screen? Hello?
Yes, we are able to see it well.
Yeah, so
we
I'll
are
just
able
start
to
now.
hear you well, yes.
Yeah, because the topic is very long, and it's actually few hours topic. So I usually show few first slides and then consider it end, because it is in two part. One is intervention, one is medicines, means
Right.
invasive and non-invasive cardiology. So I go only for the invasive because that is the first part.
Right.
Without wasting time, I'll just go ahead, because I know all the learned speaker here, the listeners here, participants know everything about everything. But just to summarize it, these are the few things that I am planning to talk on. The innovations in cardiology in last few years, mainly in last decade, and we have a lot of innovations in different fronts of cardiology that start from coronary imaging, which includes intravascular IVUS, OCT, optical coherence tomography, FFR, multi-site CT angio. In our coronary intervention, though we do what we call as angioplasty, it has a lot of new advancement in the form of different stent designs, third generation stents, biovascular scaffold, means stent which can actually resolve within 2 to 3 years. It's a big boon to the young people, and the artery becomes almost normal as it was before. The special dedicated bifurcation stents, and also a lot of new technique for doing stent with the conventional stent, bifurcation stenting, left main stentings, etc. Covered stents that helps us save an emergency if the artery is perforated. There is mesh stents which prevents distal embolization. Even in intracranial procedures, we use what is known as solitary thrombosuction stents. And so we have so many advances in our interventions. And because of this reason, now we are able to tackle those cases which we are not able to tackle. As for example, in acute massive MI, if there's a lot of thrombus, you can't put stent. But now we have thrombosuction device which can actually remove the thrombus, and you can see the thrombus which comes out, and you can see the flow immediately improved afterwards, which makes stenting much simpler. Rotablation and IVL are special technique to deal with calcified lesions. Even laser is available, which is not available at the moment with us, so I am not mention it. And because of this technological advances and more skill and more experience, now we are able to take care of those diseases which we are never able to take care before, like left main bifurcation stent, calcified vessels, thrombus containing vessels, long lesions, and multiple lesions, even post bypass surgery, SVG graft, etc. A lot of new non-coronary procedures come up on the way. Now they are all available in Baroda. So I'm talking about those things which are available to us. So that is one of the biggest thing is TAVR. That is a transcutaneous aortic valve replacement. Similarly, we can do transcutaneous mitral valve replacement, mitral valve repair, then left atrial appendage, mitra clip. There are so many things. Percutaneous aortic aneurysm coarctation management, then CRT-D device. Trend is actually not pick up so well, but now it's going to pick up. It's a control of the high blood pressure with special radio frequency ablation in the renal arteries, leadless pacemaker just less than coin size, parachute device to reduce the LV size, and there are a lot of new medicines. I don't think we have enough time to discuss on medicines, but in case it allows, then I'll discuss, but I'm sure it is not possible at this moment. Now, before we say innovation, we have to see which are the people who are responsible for this innovation. Of course, I have written name below, but just to mention, this is Dr. William Einthoven who first made the ECG machine. And when the first ECG machine came to Gujarat in, I think, 50s, it was a big event. People were surprised at how can you diagnose person having heart attack just by measuring some up and down lines outside the body. That was a big surprise. Then this is William Forsman, who was actually the pioneer for interventional cardiology. When he was a second year resident student in radiology, he put catheter actually wire in his own cubital vein and push it further and then ran to the one store up, get x-ray and then realize okay, you can actually go from your periphery to the center. For this particular thing, he was removed from his college because everyone said this is a stupid man doing some stupid activity. But that was the first step of intervention. After 20 years, he got Nobel Prize for that. Andrew Cournard is the one who made special catheters so that we can hook the coronaries and take x-rays. In past, people used to very scared to take selective coronary angiography, and people are doing only aortic root shoot. But once by mistake someone could take coronary and nothing happened. So that was one of the front to start the selective coronary angiography, and Andrew Cournard made very special curves so you can hook coronaries more comfortably and possibly. The one in the B, this here, is Andrew Grunzig, who is the first one who started coronary angioplasty. And we have to actually be very thankful to Andrew Grunzig because he is the one who started this great technology. Grunzig actually was a Swiss cardiologist who had a very short life, and when he succeeded, he was either giving lecture or in his plane because he was one of the avid flight lover as well. Unfortunately died because of crash of one of the plane few years ago, and his life ended very early, very prematurely. But his dream was the catheter-based percutaneous treatment of vascular diseases in alert and awake patient with utmost safety. And today he would have been surprised if he know how much progress has taken place after his initial things has taken place. So lately we have tremendous progress in percutaneous interventions as well as bypass surgery both. Like as for example, bypass surgery, it's complete arterial grafting, no things taken from the vein. Off pump, 90% bypass surgery in India are now done on beating heart off pump. So it reduces a lot of on pump related complications like post procedure psychosis, psychological deterioration, and recovery is also definitely faster. Many surgeons now do certain surgery with minimal invasive cuts, just half of the lower sternum, or even three small holes like laparoscopic surgeons do it, robotic surgeries. Half of the bypass are now done without blood transfusion. On the other hand, in PCI also we have equally great innovations and advancements. Like we have third generation stents, drug eluting stents, which I have mentioned before. I'm not going to detail. Of course, because of this, we get new disease as well. See, whenever there is advancement, there is always some price to pay. As for example, we have new disease which is acute and subacute stent thrombosis, in-stent restenosis, sometimes post-stent aneurysm, fracture, etc. Of course, incidence of the complication is less than 5%, and 95% people get benefited with new technology and things. Even after successful surgery, lima or radial graft can undergo spasm or got attrition when the graft doesn't remain active no more. The disease proximal to the surgery advance is far faster than otherwise. So once patient has surgery at very young age, after 10 to 15 years the disease progress, there is nothing you can actually do, and that's one of the worst scenario that we have to face. Even SVG graft, they come back with a quite diffuse native disease where even interventions become difficult. Now I just show this picture because 10 years ago I went and stayed in this hotel on 11th floor here, and I thought, oh, it's a huge hotel, tall hotel, and there's a huge theme park here, and there was a big bench here or khadda we call it. And when 5 years afterwards I went, I was surprised to see this tower. So this is just example of how technology has progressed a great. And fortunately, we medicine also are following the rest other fields. We are not behind, and that is why I am very proud to present these particular things. Now let me go to the physiological assessment. All of you know about treadmill test, dobutamine test. Now FFR is something which is new, which is fractional flow reserve, with which we can measure assessment of physiological significance of borderline lesions. So I'll give you example. See, this is a 60-year-old colleague of us who presented with acute coronary syndrome, rather exertional angina and positive stress test, and he has very tight lesion here in the circ. This is still pictures. While right had multiple lesion, but they are little borderline. So what should we do? So I plan we'll do first stent here and maybe 2 stents in the right side. That is what I thought I should do. This is the live picture. This is right coronary, and this is the circumflex. You can see the circumflex lesion is tight. There is no doubt about it. However, right lesion has some borderline lesions. So after doing angioplasty for the circ, which went off very well, you can see the circ stent and the result looks quite satisfactory. So this is pre and this is post. So I was planning to do the surgery for the right. Now very surprisingly, I had given similar lecture a few years ago in a physician club, and the doctor himself had 4 or 5 physicians attend. He said, why don't you do FFR in a patient with a borderline lesion? So I thought, okay, let's do FFR, and we did FFR turned out to be negative. So we decided, when FFR negative, let us leave this safely, and very confidently we left him, and after 3 years he is absolutely asymptomatic at the moment. So this is example of physiological assessment of borderline lesion, which you can live confidently if FFR is negative, but that is normal. So this is how we measure the pressure gradient proximal and distal to the lesion, and study shows that if you do FFR in a borderline lesion, then the need for stent goes down. The need for stent length also goes down if there is a borderline lesion next to the critical lesions. The 2 vessel disease get converted to single vessel disease, and 3 vessel into 2 vessel disease. So the need for surgery decreases, need for angioplasty decreases, more patients are managed than on medical treatment. So that is the advantage of doing this particular treatment. Even when we have left main bypass bifurcation lesions, sometimes we put stent only in the main vessel, left main to LAD. Now if there is a pinching of the side branch, FFR will help us decide whether we need to put additional complex stent or not. So end result of all this is ultimately death, MI and repeat revascularization reduces significantly, almost 40%, with help of FFR. So FFR gives you a very good important guidance in deciding what to do and what not to do. So that is available at the moment with us in Baroda. It's a fractional flow reserve additional tool, adding better assessment of borderline coronary lesions. Very good, excellent physiological assessment for long-term prognostic values. So that is the advantage of these things. This is just example of how FFR is done and how it is measured. So it's second thing is we have a lot of advancement in imaging modalities. All of us know about angiography, but we have now multi-slice CT angiography, which you can dissect in a borderline lesion when we are not sure whether we should subject patient to angiography or not. Of course, those who come with acute coronary syndrome, 100% requirement of coronary, like strongly positive stress test, we always do conventional angiography, no scope for MDCT angio. IVUS and OCT are invasive procedures with which we can actually see the vessel from inside. So that is the biggest advancement that we have. This is example how CT scan can show it. One good thing is if CT scan is absolutely normal, your calcium score is let's say 0 or less than 10, and coronary angiography doesn't show any plaque, you can say for 5 years you are not going to get coronary event. That is the advantage with the things. The biggest advantage of CT angio is at the moment in pre-tower assessment of main aorta, aortic root, aortic valve calcification, as well as the main aortic arteries and iliac vessels. So also we can assess many other non-coronary vessels with CT angio before we subject them to interventions. This is intravascular ultrasound with which we can actually see the vessel, because when you do angiography it's only luminogram. When you do IVUS you can see the character of plaque, how much percentage of vessel is involved, whether it's positive or negative remodeling, characteristics of vessels, etc., etc. So for example, here you can see at this 2 part, both looks almost same in angiography, but at this level you can see there is a huge plaque. That means this is the area which requires some management, though internal diameter may be almost similar. So angiography may miss certain lesions like this, which IVUS can detect. This is the reason why coronary angiography sometimes fails to detect eccentric plaques or diffuse concentric lesions. but IVUS can detect it. So we can decide what is the proper landing zone. Similarly, this is example of OCT. OCT makes complex angioplasty more simple, which you can decide what is type of block. As for example, whether there is no calcium at all, means lipidic lesion, fibrotic lesions, mixed lesion, or even heavily calcific lesion, or even nodular lesion. Because if you have nodular lesion, try to open the stent won't get open, and you are in big trouble. So you know which patient we should take and which we cannot. So in general, better imaging gives better hardware selection and better procedure. As for example, if the fibrotic lesion, we can do direct angioplasty. In lipidic lesion, we can use even compliant balloon and just put a stent afterwards. Mild to moderate also, we can sometimes do direct plasty, but then you require a lot of post dilatation. But if it's a heavily calcified like this, then you have to have rotablation, atherectomy, or IVL. So and if it's a very long multiple, then even surgery would be better option. So sometimes we cannot detect certain characteristics on conventional angiography, which we can detect with help of this type of technology. So whenever patient has a lot of calcium, we sometimes can see with angiography like tram track appearance here, but many times it's better to do proper imaging and be sure, so that you don't get so-called rota regret later on. Also, appropriate landing zone is important issues to be decided. Like in sometime, of course, not in all patients. Like in this patient, the result looks very good, and we were very happy and accepting it. But when IVUS was done, the OCT was done, we could realize there was a distal dissection. You can see this flap here, that is known as dissection. So it was distal dissection, which was not evident on angiography. And similarly, proximally, though the stent looks good, that was not malapposition. Now we realize malapposition of stent is one of the most common cause of restenosis or stent thrombosis. So what we have to do is, in this patient, we obviously put one extra stent distally here and did better post dilate with larger size balloon. So nowadays we do common that we stand maybe 2.5 millimeter, and proximal area or vessel may be post dilated with 3 millimeter balloon. So stent is made to touch the wall everywhere. That makes all the difference. Also, when we do bifurcated stenting, it helps us wiring distal edge of the strut, which gives much better long-term results. So in general, with the help of IVUS, we can take care of so many complications which otherwise we don't see with conventional angiography, like malapposition, geographical miss, stent under expansion, edge dissection, or plaque protrusion. So all these problems can be taken care of with the help of this device. So we cannot actually work blind. We have to see properly rather than only imaging. If you can do a proper in-sight imaging with 3D, we can see so many things which otherwise we can't see. It is like actually seeing vessel directly from within. That is the advantage of technology, and that is what we call is multi-modality intravascular imaging during PCI, making it better. Also, there is a lot of advancement in interventions tool, making us more comfortable and doing or tackling the cases which otherwise we are never doing it. Like third generation stent means stents have thinner stunts, so it can be more can negotiate the tortuous vessel more easily. Otherwise, the stiff stud, you cannot actually go through it. They were so rigid that you cannot go across long vessels or tortuous vessels. With thinner stud, that things become possible. Stainless is more or less replaced with cobalt chromium, which is more inert, causes less reaction, less post-stent problems. Biovascular, which can be absorbed completely, and very long trackable stents. This is an example of how stent diameter has, strut diameter has gone down. It has gone down quite significantly. You can see this is the old one, and these are the new one. Also, now we have drug-filled stents and so many technologies. Of course, biovascular scaffold is still large and sturdy, but we have to prepare the region well and we can use it. When there is a lot of thrombus, we have to first remove the thrombus, especially in acute coronary syndrome. When young patient comes with massive MI, many times his lesion is more thrombotic rather than because of plaque. And here, putting stent is not important. Removing the thrombus is more important. So whenever there is a thrombus, we can see the filling defect as it is seen here. Can you see this filling defect? And if you don't remove the thrombus, there can be distal embolization. So even if technically successful angioplasty, if there is a lot of distal embolization, no proper re-establishment of blood flow, the long-term outcome is very bad. So that is why we have to remove the thrombus. We have a lot of medicine to tackle the thrombus, but we have mechanical means also like this thrombosection device, and we can actually remove the thrombus. When you remove the thrombus, you can see such thrombus. And such a small thrombus can kill a big 6-foot man. So if you remove it timely, we can get very good long-term outcome. Of course, whenever thrombus cannot be removed completely, sometimes we put what is known as mesh stent or M-guard stent. That is more important for carotid plasties because it prevents distal embolization. In coronaries, we used to do this, especially young people. The problem is this remains forever, and this is not available as a drug coated. So long-term prognosis is not excellent, but in bailout situation, M-Guard stent can help a lot. This is an example of a patient. Can you see the heavy calcium here? This one, this calcium actually you can see before we inject the red eye. So this is a calcium. Now what should we do? In past we used to subject such patient to surgery only because there's a lot of calcium and very long lesion. Now because the relatives wanted, can you try it? I said no, we should do it with rota. So I tried with the lowest possible balloon, and you can see when there is calcium, it doesn't allow even the balloon to pass through. So calcium causes a lot of problem. It doesn't allow balloon to pass through. Even if you pass through, it doesn't allow balloon to open, and balloon can get ruptured. If you try very high pressure, artery can get perforated. And even after balloon, if you put stent and if the calcium is still there, it will not allow stent to open or expand well. And if the stent does not expand well, the restenosis rate is extremely high. So we have to be very sure before we put stent, the artery is very well open. So what I did a rota ablation 1.25 burr, and you can see rota works like a drilling. It revolutes at around 1,50,000 to 1,80,000 revolutions per minute, and actually it makes calcium into small fragments which actually gets circulated in distal circulation, and later on by ARI system they are removed. So this is known as rota ablation. After that we did a balloon. You can see the balloon could pass very easily distally, and then I did proximal dilatation. Again, the balloon doesn't open well. So what should we do? In that case, we have to use larger burr. So larger burr of 1.5 was done, and then balloon could open here. You can see that balloon opened very well. So after the balloon opened, it was relatively simple. Then I put a stent, and you can see the final result. You can see the pre and post result. And you can see right coronary is even more aggressively calcified. So this is just example of more complex rota case, and this is the final result. You can see the difference between pre and post. This is pre and this is post. This is an example of a patient who had a bypass surgery a few years ago, but with severe refractory angina. And when we did the angiography, we realized there was a very calcific left main end circumflex. Lima to LAD had occluded, and now doing second surgery was very difficult. So the only option was to do angioplasty from Lima to from LAD to left main. Again, because of very heavy calcium, this is a case where we have to do something. But when the artery is very big, rota doesn't work. In this situation, it's IVL, which is intravascular lithotripsy, which we learned from urologist actually, that is being used. This is an example of IVL, intravascular lithotripsy, and post lithotripsy result. So in general, when there is non-dilatable lesion, we have now special OPN balloon. You know how much pressure we give to open the arterial lesion? Usually it's a 15 to 20 atmospheres, but IVL is the OPN is a new balloon, high pressure balloon, in which we can give up to 45 to 50 atmosphere of pressure. So that is the pressure with which we can open mildly calcified or moderately calcified lesions, or lesions which are very fibrotic, it doesn't give way. Of course, rota ablation, orbital atherectomy, IVL and laser are the best way to deal with when there is a heavy calcium burden. This is an example of how rota looks like in magnified views. This is how it works and excavate the calcific measures. This is OPN balloon with a very high pressure tolerability. It is 2-layer balloon, very different technology. It doesn't cause what is known as dog boning, which is very common problem if there is very hard fibrotic lesions. And this is intravascular lithotripsy, which emits the radio frequency waves, and same way as the kidney stones are removed or destroyed, it can actually make crack into the calcium. It doesn't remove the calcium, but it makes crack and make balloon angioplasty more successful afterwards. So that is example of shock wave lithotripsy. Now, this is another example of just 38-year-old man who came with some thrombotic lesion. I hope you can see the lesion here on the left side. So there was a tight lesion here. So after thrombosuction, this is what remained. Now he was too young, just 38. So what we did, we put a very special type of stent that is known as a biovascular scaffold. And I'm very proud to say that this is being made in Vapi by one of the Indian company, that is Merrill Life Science. The advantage of this biovascular scaffold is the stent get completely absorbed within 2 to 3 years. So after 2 to 3 years, artery becomes normal, vasomotor tone is back. You don't need to depend upon lifelong dual antiplatelet. And suppose if the block is distally, patients can be undergoing even the surgery after a few years in case he requires with new lesions in those area. So this is example of biovascular scaffold, which is new thing. This is the example of how it looks on IVUS. As for example, this is stent at the end of 6 months. At the end of 2 to 3 years, it start completely absorbing, but at the end 4 years, 100% completely absorbed. You don't see any remnants of stent or any of the material related. That's the biggest advantage of this type of third generation stents. Then this is example of osteal lesion. When there is osteal lesion in past, we always used to do surgery because osteal lesions are more difficult to tackle. We cannot put stent exactly at the ostium, but now we realize we can put stent across left main, and this is how the angioplasty is being done for the left main LAD lesion, which are not amenable to surgery. Angioplasty in those days. This is the example of left main lesion. When patients are more than 80, usually surgery is avoided. Even patients don't like to have surgery done because there are a lot of post-surgical, post-morbid problems, especially other associated symptoms like COPD, renal involvement, etc. So these are the cases where angioplasty is big boon. And this is example of left main lesion, you can see it. And this is a post-plasty to the left main. Nowadays we do left main bifurcation plasty as well. So in past, suppose if there is a patient like this, we would used to do angioplasty for LAD, RC, culprit vessel, and then surgery. Now these are the patient where both the lesions can be subjected to angioplasty. This is an example of bifurcation left main lesion. Means there is a definitely critical lesion left main, but lesion progress into the LAD as well as circumflex. I hope you can see it in different views. And this is a post-plasty. You can see the two stents, one in the LAD and one into the left circumflex. So these are multiple different techniques how we can put a bifurcation stent. That is more technical issues. And another new thing has come is a drug-eluting balloon or drug-coated balloon. Whenever a patient has angioplasty done, and if he comes back with restenosis in the stent, we sometimes do the second stent into the stent. But when there are more than 2 layers of stent, it becomes smaller and smaller. And when it becomes smaller, the restenosis rate becomes quite high. So nowadays we know what is new technology is not to put third layer of stent, but to do what is known as a drug-eluting balloon, and that can reduce the restenosis rate more significantly, provided patient doesn't have dissection. Also, if the side branch is pinched, instead of putting another side branch stent, we do what is known as a drug-eluting balloon in the side branch. So this is also new technology. Again here, one of the Indian company has got now FDA approval in US, and that's a very big achievement that we Indians have. You can see, as for example, if you use a drug-coated balloon, it gives better result than the small stent. Small stent which is lesser than 2 millimeter. When the vessel, smaller the vessel, more the chance of restenosis. So in very small vessel, usually 2.25 less, we don't put stent. Those stents are available. So in the very small vessel like this, drug-eluting balloon is one of the best options that we can use. With again drug-eluting balloon, need for dual antiplatelet agent is less, neoatherosclerosis is less, instant restenosis is less, and vessel stent thrombosis is less. So there are many advantages. Many times we do high risk angioplasty, means patient is poor pumping, left main, they are in heart failure. Many times they are put on mechanical support or mechanical cardiovascular support like intra-aortic balloon pump that is easily available. But now many other devices like Impella device, as for example, is a pump which is put inside the LV through femoral root, and it can give 2.5 to 3 liters per minute of blood cardiac output with each beat. And even in very sick patient, angioplasty is possible in this scenario. So this is an example of how Impella works. Also, I have mentioned about the covered stent, which saves our life when there is vessel perforation. Then there are very long lesions, as for example, this is very long lesion you can see. And post angioplasty, very long 60 millimeter stent can work actually. So in general, in past we used to do angioplasty for single ideal lesions. Now we do multi-vessel long lesions, calcific lesions, left main, bifurcation, etc., etc. So that's a scenario that has changed. CTO means chronic total occlusion. We used to avoid touching it, but now even they are touched, especially patient lot of large myocardium which is viable. Then we do angioplasty even after the surgery. As for example, this patient has Lima to LAD pattern, but SVG to PDA has critical lesion here. You can see this tight lesion. This is a SVG graft to PDA. You can see the lesion, and this is how post angioplasty can look like after angioplasty and SVG graft. And then there is an example of patient who came back after angioplasty. He had a very significant angina, and you can see left subclavian artery stenosis, as well as you can see lesion into the Lima graft. This is Lima graft, and this is LAD. So at the junction there was a tight lesion, and there was lesion. So what should we do in this situation? The first I did angioplasty for the Lima. You can see the stent here, and the lesion is gone. And then we did angioplasty for the left subclavian. So after taking care of these two lesion, patient become totally asymptomatic. We have a lot of studies which shows that those cases where surgery cannot be done or surgery is not, patient is not ready, we can do a lot with intervention. This is one of the greatest latest study, which is known as optimum study. Outcome of PTCA or percutaneous revascularization in a surgically ineligible patient, means patient where surgeons have refused the surgery and they had very high grade lesion like multivessel or left main. As for example, very calcified bifurcation, CTO, meant anatomically or technically challenging cases, and these are the cases where intervention was done and long-term result shows much better outcome compared to if they were left without medical treatment. Even surgeon has predicted mortality of 10%. The mortality was reduced to less than 5%. So in general, those patients who are refused by surgeons or those who are not amenable to surgery because of many comorbidities, angioplasty can be offered to such situation. Even in left main, long-term result says that overall outcome is same except restenosis rate for angioplasty is high. So definitely restenosis is the biggest disadvantage or Achilles heel at the moment we are facing. But other than that, angioplasty gives a lot of long-term results. So in general, cardiology is now entering into surgical den, and it is this type of phenomena or feeling that we have, but we come out with reasonably good outcome, and that is what we would consider as a great thing. Now this is example of almost 80-year-old lady. You can see the very heavily calcified aortic valve. A peak grade was 90, and because of her age, neither patient nor surgeon were ready to touch her. Now what should we do in this situation? We first did the balloon dilatation with rapid pacing. After that, there is a self-evolving valve. This is a Medtronic evolute valve was introduced, and the gradient became less than 10. And this patient is now doing very well. This is an example of the Stower transcutaneous aortic valve replacement. Two type of valves are available: balloon expandable and self-expandable. This is an example of mitra clip. You can see there is severe mitral regurgitation. In mitra clip, we puncture more or less similar as when we do the BMV. Of course, the puncture size is a little different, and the clip actually help put two valves leaflet into the vicinity with each other. You can see the clip will do the clipping job. Everyone knows, but surprise, unfortunately, the cost is the biggest issue. Then this is a parachute device. Parachute device can take care of aneurysmal left ventricle, and it reduces the size of left ventricle related complication. Those patients in whom we cannot give oral anticoagulants and they have high risk of thrombus generation left atrial appendage, like patient with atrial fibrillation and high bleeding risk patient, we can put this device and actually close percutaneously left atrial appendage. Atrial septal defect, everyone now knows we can do ASD closure device. This is an example of Amplatzer closure device. Unfortunately, the window clears are not very clear, but this is how you can actually take care of ventricular holes or the atrial holes. CRT device has made a big difference in life expectancy as well as symptomatic status in a patient with a severe LV dysfunction and left bundle branch block. Unfortunately, only 10 to 15% patients with severe heart failure are amenable to CRT device because it requires left bundle branch block to be existent in the first place. But whenever you put this device, it improves pumping quite significantly. Now this is an example of lidless pacemaker. It is smaller than size of a coin actually, and you can put it from femoral root. So no more surgical procedure. The biggest advantage is chance of infections are less. Patient goes home more faster. No need to have restricted mobility. Of course, the biggest disadvantage at the moment is the cost is much higher. if you put a single chamber leadless pacemaker, it costs about 7 lakhs, and if it's double chamber, it is almost 10 lakhs. But it's the biggest miracle, especially very elderly people or those who have blocked subclavian veins or those who don't want surgery here. This is definitely one of the biggest boon that we can face with. All of you know that atrial flutter, and not only SVT, even atrial flutter is subjected to ablation. It gives very good therapy. Even atrial flutter, fibrillation, in which success rate is very less, recurrence rate is very high after ablation, is now being successfully tackled with cryoablation. At the moment, cryoablation is not available in western part of India. It's available in Hyderabad and Delhi, and it again costs about 8 to 10 lakhs. But the advantage is even atrial fibrillation can be taken care of with invasive monitoring and treatment. Heart transplant has become definitely a big thing in reality, and this is one of the smallest heart transplants that are done in small young baby. Now, heart transplant is available in Gujarat also. That's the biggest thing that we should consider and be proud of it. Of course, before we start any new intervention, we should know how to finish it. That's the most important. Again, these two are the pioneers for ultrasound or echocardiography development. They are Helmut Hertz and Adler, and they are the one who had a lot of basic pioneering work. Now, presently in echocardiography also we have a lot of advancement that is known as LV stent and tissue Doppler. Those who are doing it, like Dr. Antani and others, they know what are the technological advances. If we can identify LV dysfunction, which otherwise our naked eye won't identify with the help of LV strain. So there is a lot of technological advancements. Even 4D echo is important because we do a lot of structural interventions. With 4D, actually you can plan your surgery or interventions more logically compared to only 2D echo. So that is the advantage of 4D echocardiography. Of course, the biggest illusion we always face with our eyes is brain sees what brain want to see actually. So eye sees what brain want to see. As for example, you can see the illusion. Now this is a carotid angioplasty where we actually remove such amount of embolized material with the help of filter. This is a pre and post carotid angioplasty result. So angioplasty also comes under way of cardiologists at the moment. Then this is, you can see huge calcified aortic abdominal aneurysm, and that is also best taken care of with help of device. This is a true lumen and this is a false lumen with a lot of thrombus. We can take care of this by either surgery or percutaneous. This is an example of putting stent in this. This also we did at Bilalmin. There's a post stenting. So in general, it's never too late to learn new technology that we learn from Saturday Club people only, our pioneers. And I think we should go ahead and do it. Now I will stop here because medicines are too many. Then it will take another 1 hour because I think we have to have half hour or 1 hour, 10-15 minutes of discussion also. So Satish, is this over or should I go ahead, because there's still a lot of to talk, but I think there's a limit at this moment. Whatever you suggest is acceptable.
If you can spare 10 minutes, it's okay because it's 9:40. I mean 8:40, so we can carry on till 8:50 and 10 minutes of discussion. We can.
Okay, that's very good. In that case, I'll go a little fast about new medicine because see, medicine will be more pertinent to many of people around because that is what they can actually use it. So we have a lot of new medicine. These are the example of few. Like Novak is new oral anticoagulants. Then we have new lipid reducing medicines, new blood pressure medicines, new thrombolytic agents, and most important, new heart failure medicines. The medicines have improved so much that 1 minute, there's something. Medicines have improved so much that we feel as an interventional cardiologist we may have to retire in next few years, but fortunately by that my career will be over. But this is what ultimately future cardiologists will be doing. The medicine will take care of this disease so well that our interventional textbook in 21st century will say that in 20th century, 21st century cardiologists were like a plumber removing the plaque from the coronary vessels. Now the atherosclerosis is no more existent. It is very well taken care of by birth medicines or genetic manipulations, and you don't need to do any interventions anymore. This is an example of new oral antiplatelet agent ticagrelor, and it has reduced stent thrombosis quite significantly. It's a reversible P2Y12 receptor blocker, and compared to clopidogrel, which is most effective anti-platelet agent hitherto, it reduces prognosis or restenosis rate by another 10 to 15%, and that is translated into reducing stent thrombosis and related complications. I think the slide is not moving. So ticagrelor, stent thrombus, which is one of the biggest problem that we are facing at the moment, is reduced by almost 40%. Of course, now reduced stent thrombus is because of multiple reasons. One is proper taking care of stent during angioplasty, giving more antiplatelet intravenous medicines, proper stent appositions, and proper stent size selections. But this medicine also plays a very big role in reducing stent thrombosis and related problems, not only at the end of first year, but even at the end of up to 1 year. So that is the biggest things. So in general, it shows superior in reducing mortality compared to clopidogrel, which also had shown improvement compared to ticlopidine that is used in the past. So this is an example of how it reduces stent thrombosis. Then another is a Talos registry, which shows that with newer third generation stent, where the medicine is absorbed within 1.5 months, there is no need to give dual antiplatelet agent for more than 30 days in low risk patients. So if patient is high bleeding risk or low thrombotic risk, we can actually reduce dual antiplatelet agent at the 1 to 1.5 month, because the bleeding risk is remaining more or less same, but thrombotic risk goes down quite significantly at the end of 1 month. So we can consider dual antiplatelet agent for about 1.5 to 2 months, and then replace with a single antiplatelet agent. This is more true if patient has atrial fibrillation associated, because those patients with atrial fibrillation, we have to put them on some oral anticoagulants like acetrom, warfarin, or newer one. So we cannot give them 3 medicines. So these are the specific group of patients, or those who are on the artificial valve. We can continue with dual antiplatelet agent for 1 to 1.5 months and discontinue one of them and continue with one antiplatelet agent with one of the oral anticoagulants. So this study shows that compared if you stop this medicine at the end of 1 month, composite endpoint of thrombosis is not different, but in bleeding it shows significant reduction. So we can definitely reduce overall mortality significantly by reducing the bleeding problem. That's the biggest advantage. Also, another study shows that at the end of 1 year, if you to continue only one of the two, it's better to continue with clopidogrel rather than aspirin. We used to continue with aspirin, but now new study says it's better to continue with clopidogrel at the end of 1 year, which gives better long-term prognosis and reduced chance of restenosis and thrombosis. That is the biggest advantage. This is an example of 1 month versus 12-month dual antiplatelet in those patients who are high bleeding risk, if high thrombotic risk. If patient is high thrombotic risk, it is better to continue them for 12 months. But if they are low thrombotic risk and high bleeding risk, it's better to continue for 1 month. So that is what we have learned from last thing. The biggest advancement taken place is in heart failure treatment. At the moment, we have few medicines which reduces the mortality, like ACE inhibitors, angiotensin receptor blockers. ARNI is one of the biggest player on the block. Beta blockers, mineralocorticoid receptor blockers, SGLT2, again another new player in the block. In those who cannot tolerate ACE inhibitors, ARNIs because of renal involvement, or black people, isosorbide dinitrate and hydralazine combination also has some important role in mortality. And ivabradine, which is IF channel blocker, those who cannot tolerate beta blocker or do not achieve low heart rate in spite of adequate dose of beta blocker, also reduces mortality. So these are the huge number of medicine which actually reduces mortality, which is very big achievement, and we can see a lot of improvement in outcome of the patient with heart failure. There are some medicines which are still used, but they are more for symptomatic. They don't make any difference in mortality, like as for example digoxin and loop diuretics. On the other hand, heart failure therapies evolve a lot, so much so that now there are heart failure clinic and heart failure specialists who work only with the heart failure. So treatment of comorbidity like anemia, as for example, surgical correction of problems like by bypass surgery, AVR, MVR, or putting CRT-D device, or even heart replacement as a last therapy. So ARNI, which is sacubitril and valsartan combination, it reduces mortality by 20% compared to enalapril, which is proved one of the best heart failure management. So you can say additional 20% reduction. If you consider with placebo, it will be more than 40 to 50% risk reduction. That is really huge amount of reduction. Similarly, we have dapagliflozin, empagliflozin, and canagliflozin. They are SGLT2 blockers, which are anti-diabetic medicines, but they also causes glycosuria, natriuria, and many other pleiotropic action, and that is how they reduces mortality of a heart failure patient, whether patient has diabetes or no diabetes. In both the group, it reduces mortality quite significantly. Third medicine we have now is vericiguate, which actually is a newer medicine which doesn't work by conventional method that we have. It actually increases cyclic GMP. So we call it energizer. It increases mitochondrial level of cyclic GMP, and that is how it improves the cardiac contractility, and it reduces chances of heart failure quite significantly. So there's another new medicine that is come, and I would consider this may come as a fifth pillar. So if patient is already on maximum possible medical treatment, even in that case, it reduces mortality by 4 to 5%. Which doesn't look very impressive, 4 to 5%, but these are the patients who are already on 5 other known medicines that I have already described. We call the medicine's brand name is Verquo. That's why I put this slide to remember, make you remember that it is known as Verquo. Then bempedoic acid is a new medicine which acts on the synthesis of cholesterol one step before statin or HMG coenzyme co-reductions medicine works. So bempedoic acid prevents conversion of citrate and coenzyme A into acetyl coenzyme. That's the first step in genesis of cholesterol, and that's the additional anti-cholesterol medicines. Of course, still statin remains a central of cholesterol control, but if you have this new medicine, it works definitely better. Then inclisiran and PCSK9, they are too costly at the moment. They are given intravenous, but they are usually reserved for those patients in whom statin or other standard medicine fail in spite of maximum things. So in general, we have to accept innovations. This is just an example of one innovation which everyone knows, that when it was first installed, people were scared of using it. So one innovator thought, let me put one man with one leg on here and convince people how it works. And you know what happened? Instead of convincing people, say, see, if you go and stand, this is what happens. So issue is many people are so scared of modern technology innovations, but in actual sense, they work the best. I think there's some technical errors. So in general, with modern technology, mortality has gone down.
Painkiller
Nothing.
No, sorry. So in general, in future, atherosclerosis may become extinct because of genetic manipulation and diagnosis even before the birth, very early detections, powerful anti-atherosclerotic medicines, which I already mentioned, and definitely lifestyle changes. So the modified plumber would no more remain modified, and they may not actually get extinct. That is what our textbook in 2050 would say. Cardiologists were treating the atherosclerosis like a crude plumber, but now this no more exists. This is what we are doing at the moment, and this is what I would consider. Whatever technological development occurs, it's ultimately prevention that is the most important, and that is what we have to give more importance to. So I think I will end here at this level.
Thank you, Dr. VC. You can stop the screen sharing.
Yeah.
That was a real roller coaster ride and overview of recent advances. You covered so many things, and in a very brief, but we could understand every bit of the technicalities that we got a good view of what is happening in the field of cardiology. Nitty-gritty we don't need to know, we being non-cardiologists, but really it was wonderful to know so many things are happening in the field of cardiology. So now it's open for discussion questions. Dr. Sulin has asked percutaneous mitral valve replacement. Is it done in Gujarat, and is it successful?
Yeah, I think there's a question for Sulin. It's being done, but at the moment the biggest hurdle is a cost, because it costs about 25 to 30 lakhs. So in Bailal we have done one case. In Gujarat probably 10 to 20 cases have been done. So it is being done, but see, at the moment still we have very good surgeons available. So those patients who are amenable to surgery is always preferred, because surgery can be done in less than 5 lakhs. But see, this is the case where patient has a tissue mitral valve and it had degenerated, and so percutaneously valve in valve was done.
Any other question, comment? Jagdish Chinnappa has asked, how aggressive should one be in treating hypertension and hyperlipidemias? Dr. Jagdish is a pediatrician from Bangalore.
Oh, okay, okay. Oh, that's great. Good. Means there are people outside Baroda also in the group.
Yeah, there are a lot of people listening to you. I mean, beyond the numbers which you are seeing on the screen, because we are live on YouTube also.
Oh, that is very surprising and very pleasant surprise actually.
Yeah.
Now see, basically we have to be aggressive in control of both these conditions, high blood pressure as well as cholesterol, because these are the two most important primary risk factor for atherosclerotic heart disease as well as peripheral vascular disease. So more aggressively control both this disease, better it is. Of course, we should not be so aggressive in patients who are not high risk patient and those who cannot tolerate antihypertensive or statin and other medicines. Like if patient has nearly normal statin, no coronary risk factor, there is no point in reducing cholesterol level or LDL level to less than 100 and subjected them to the myopathy and other side effects of the statin. On the other hand, those who are diabetic, hypertensive, very strongly positive family history and very high risk for atherosclerosis, all already heart patient. In those patients, we have to have target that LDL should be less than 70 to 80. It means lower the better in those cases, unless they can't tolerate it. And if you can't tolerate statin, we have many options, but we have to be aggressive. As far as blood pressure is concerned, in younger people, we have to be very aggressive and see that blood pressure remains 130 to 140. I would not suggest that it has to be 120 or less, because in aim of over control of blood pressure, like over control of diabetes, if there is a hypotensive symptom, they are more harmful. Especially in very elderly people, if you reduce blood pressure too much, because they have atherosclerosis, the blood pressure may not actually go down on our sphygmomanometer, but actually they get hypotension. So in those patients, we have to be careful. But if you do not make patients symptomatic by the side effect of medicine, you should be as aggressive as possible. Anyone other can also comment on my answer. Like I can see Dr. Hemant Antani and I can see many senior physicians, Kiran Shah and other Chetan Shah. All of them can give comment.
Hemant is Sant, not Antani here.
Oh, I thought Antani.
Antani also.
So what is Dr. Hemant? I say
Hemant
Hemant Anant Sant.
Sant,
Hemant
yes.
Anant Sant. Okay, okay.
Anant,
Yes.
But Hemant Sant I know is a very academically active man.
yes. I think there are no more questions or comments. So we end the session here. Thank you, Dr. V.C. Chauhan, once again for being with us. And we look forward to similar such talks in future from you.
But
So
see,
thank
before
you
we
so
stop
much.
this, I ask you, all of you, okay, how comfortable you feel with online compared to offline? The interaction is always less online, while comfort at home is better with online. That is what I feel.
Sir, thank you very much, Dr. Chauhan. Thank you very much. I am Dr. Jagdish Chinnappa here.
Oh, thank you very much.
For me, I have to only be offline. I cannot be online.
Yes,
I can only be online. I cannot be
yes,
offline.
Yes. That's very good.
There is more attendance because it is online.
Yes, I agree. And you are at comfort of your home. You can
Yeah,
join
otherwise
anywhere
at
from
8
the world.
o'clock, it was difficult for many to go to the place of lecture.
Yes, that's correct.
So for Saturday Club, I think there is no doubt about it being online only. Offline will be very difficult to hold now. Satish Bhai Sai is not now practicing here. His hospital has been donated to some other trust.
Oh,
And people are now habituated to
yes, that's
have this
correct.
morning session in the comfort of their home.
Yes, that's
So
correct.
Saturday Club should go on with online only. Of course, I agree that offline is good to have interaction, more in-person talks with the speaker and all that thing can happen only offline.
Okay.
No, but online, the moderator is so good that not only reads the chat, but does not interfere and moderation. And we are very blessed that Satish Pandya has continued
Thank
this
you.
tradition and our learning continues.
Anand, Hemant, it's an honor and pleasure to carry on with the legacy started by Satish Bhai Sai, Jagdish Bhai, Vaishnav Sahib and all stalwarts of our city. So I'm doing little bit of my efforts to continue that legacy. So anyway, thank you for the compliment.
Well done.
Thank you.
Thank you. Thank you. So we end the session here. We meet next Saturday again. Thank you all. Thank you.